Welcome to SkinSync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
So we're going to talk about PDE-4s today. We know, Dr. Hawks, that you've been really deeply involved in clinical research with psoriasis and atopic dermatitis medications. So we want to focus our attention today on the PDE-4s. Could you kind of take us back to the history of it? I know Dr. Hannafin maybe was involved in the early findings of PDE-4s, but take us back to the history. How did they make their way into dermatology? If you could just kind of break down the MOA for us in a way that makes us understand why these are effective.
Yeah, so I think the way that PDE-4s were kind of picked up is that this is a family. So we talk about PDE-4, but actually in the phosphodiesterase family, there's a whole host of PDEs. I don't know, somewhere in 10 plus 11 or 12, somewhere in that area. What we found from the early science was that PDE-4 tended to be more restricted to the immune cells. And so it became an obvious target for potential inhibition. If we could hit some of this key pathway in driving activation of these immune cells, maybe we could help have this effect for inflammatory conditions. So I think this was an early sort of stretch for shutting off a pathway driving activations. I think the easiest way to remember it, I remember in residency, everyone's trying to remember, well, does cyclic AMP go up or down? Forget it. Cut out cyclic AMP, because you can think of PDE-4 activates NF-kappa B. NF-kappa B is a pro-inflammatory pathway. So you don't even have to think about cyclic AMP. So the way I think about this MOA in general is that inside a lot of these immune cells, you have this intracellular mechanism by which it can drive the activation of NF-kappa B, which is broadly pro-inflammatory. So that's why the systemic inhibition of PDE-4s hits Th1, Th2, Th17, because it's kind of this non-specific pathway. NF-kappa B tends to be very broad, kind of like the TNF pathway. So, again, it's this interesting idea that apremilast, as an example, is viewed as being very safe, but it actually has a pretty broad impact on the immune response. But the converse to that is what's really interesting about why topical PDE-4 inhibition works for a number of inflammatory conditions, because it's not just type 3 or type 2 or type 1. So I think we've kind of come full circle in seeing the drawbacks from systemic exposure, but seeing the benefits of topical application working for multiple conditions.
And that brings us to our next point. We are really trying to move away from using topical steroids, right? So we are fortunate enough now to have several tools in our toolbox, if you will, that are non-steroidal in terms of anti-inflammatories when it comes to atopic dermatitis, psoriasis, sebderm. Do you feel like the topical PDE-4s have really kind of created a niche for themselves? And if so, from your perspective, which of these inflammatory dermatoses do you feel like it's most effective?
Yeah, I think we've seen two major different MOAs come out in the topical space that have kind of crossed over in, psoriasis and atopic dermatitis. Where I think these medications have made a big difference is that across the board, topical steroids are just inappropriately used. They're thrown at patients often. They're ignoring joints. They're ignoring BSA. It's just an easy thing to get people in and out of the office. And that, I think, goes to the stress of our system, that people are just trying to get home to their families and finish documentation. And that's not a good system. And so I think the topical steroids, they're readily available. They're cheap. You can give them a big tub and go home and I'll see you in a little while. And that's not necessarily good medicine. And so I think you're hearing more about this topical steroid stewardship, right? That using topical steroids more appropriately, using them thoughtfully, and when they're not working, stopping, right? And moving on. But one of the practical components to topical steroids is that these regimens are complex, right? You give them a hydrocortisone 2.5 for the face, and you give them triamcinolone for the body, and then you give them clobetasol or betamethasone for the hands and feet. They can't follow that. So I think one of the big advantages to the topical interventions has been that you can use these anywhere, right? That we're getting away from the side effects with chronic long-term use. It simplifies the regimen. I think particularly one of the really interesting areas this works well in is for application and treatment of scalp psoriasis and also seb derm. Some of those cases are hard to tease out. You don't know what they have, especially if it's isolated. So I think that was a big advancement. A lot of female patients talk about the foam, right, and how much easier it is to get in the hair. And I learned very quickly that it's very hard to get female patients one, they don't shower that often in terms of shampooing their hair, right? So that was something patients were saying, like, you want me to use this shampoo for seb derm, and I don't wash my hair that much. I shower, but I'm not showering and washing my hair. And so I think you start to see some of the like lifestyle interference with treatments. I think having a therapy that works for two conditions that can mimic each other, we talk about SIBO psoriasis, for example, but having a therapy you can use across the whole body, not being worried about using in the genital area or underneath the breasts or abdomen or the axilla or on the face. I think this has kind of simplified the topical burden, and once a day, right? I think these are other like this makes life better for our patients in a lot of ways. So I think this has been a really good movement with the topical space. I think the challenge is that these can still be expensive for patients, right? So like every new therapy, like we want to create pressure to drive the cost of these down so they're more affordable, but they fill a need of benefit.
Absolutely. Access can definitely be an issue. And one thing I think is interesting to point out within the topical PDE-4 inhibitor space, they're not all created equal in terms of efficacy. And in doing a little bit digging, I realized, there's kind of these three different binding sites, and you have the glutamine binding site, metal ion binding site, and then the hydrogen water binding site. So depending on the molecule, it's different from one to the other, which really correlates to their efficacy. Like topical roflumilast going to be often working a little bit better than topical crisaborole.
Yeah, and I think this is a parallel to what we've talked about with the TYK2 inhibitors, right? So we are getting better at developing therapies. The second generations and third generation therapies are better. So, you're talking about the topical roflumilast as having, a much better on target effect, right? It hits that pathway better. It stays there better. We're not seeing the drawbacks of stinging, burning, the skin sensation response. So, I think this is an evolution, not even in the science to get things like this into topical, but even on first generation treatments. So I think the topical space is challenging. These companies that are working in this space, like, they're fighting for a little piece of the market because the steroids have this huge hold on the specialties and primary care. They're happy to give topical steroids, but they don't know about these medications. And, I think even providers and the specialties they struggle. Like, steroids have just become part of the culture of taking care of patients. But definitely the newer therapies do a better job at, as you mentioned, at hitting the target.
So we have several options. You mentioned there's newer therapies now that are non-steroidal. And I feel like kind of like with the biologics for psoriasis, how do I pick? Why are you choosing topical roflumilast over other agents?
Yeah, so I mean, we're really talking about the aryl hydrocarbon receptors, and I think you are seeing that kind of work for eczema and psoriasis. You're really not picking up, I think, some of the newer indications that we start to think about. Topical roflumilast, like, you pick up seb derm. There's a lot of interest in starting to apply this to other conditions. So, would it work for intertrigo, which there's no approved therapies? We know that all the things that I learned through residency that might work for intertrigo, none of them ever worked, right? I was like, oh, it's candida and you use anti-inflammatory. It just didn't, it's inflammatory, right? It just is. And so to have something that can really calm down skin inflammation, not be worried about that. I think I feel like the PDE-4 medications have kind of shown the more robust aspects of it. It may be that aryl hydrocarbon receptors are pretty good in AD and psoriasis, but that may not really spill out into some of these other pathways. So in this case, where on the biologic space or systemics, we're trying to be more sniper-like. We want to hit the one thing we want to hit and leave the rest of it alone. In topical, you kind of want the opposite. It's a totally different ballgame here. So I think PDE-4 is broader, right? It hits a lot of pathways, and that means this medication will probably work for multiple indications. So I think we're going to see this excitement overall. I think, again, access is an issue, cost is an issue. So, there's going to be these pockets you're going to practice in that, I think you're going to go with the one that you can use. But I think the scientific backbone to why PDE4 blockade may actually have a broader reach in dermatology, I think is pretty sound. And so I think that's one clear advantage. But head to head in psoriasis, like honestly, getting these patients off steroids they've been on for many years is a good thing. So I think that's the first jump to let's just not just throw steroids at everything. But I think people need to kind of find what they're comfortable with. It's interesting to try these topicals, and I know you don't have to admit it, but I know you've all tried some of these samples, and whatever works for a bug bite, or what about a mosquito bite? And I think people are kind of dabbling here a little bit that they may not work for the same things. And I don't think we haven't done a good job at teasing that out yet. But I think I view the PDE4 as being a little bit broader, more pathways. And so I think you'll probably see more development there. And we haven't seen, tapinarof, like topical tapinarof, really go outside of where it's been, right? So that's kind of the way in my mind I think about it, that, if it's a little bit ambiguous, TD4 inhibition topically probably works in a lot of those things. And that's an advantage to the patient.
In terms of this like off-label exploration, if you will, thinking about oral PDE4 inhibitors, which we have as apremilast, it's not a sniper. We know that, right? And we know it has its pitfalls, but it does have its niche. Do you have a particular clinical scenario where you reach for apremilast, or do you think about down the road in terms of this off-label exploration? Are there other disease states that it might be beneficial for?
I might be the wrong person for this one. But,
we were awfully nervous to ask you this question.
Yeah. Look, I'll always say what I believe. I'm not going to come up here and try to say something that's going to be a spoon-fed piece of information. Could apremilast work for other conditions? It might. But the problem with it is it just doesn't hit any of those pathways really well. Now, I do think you may have the development of a better version of hitting this pathway. And then the question becomes relevant. In psoriasis, I made it pretty clear my thought here. And this is because we have, 14 medications now where the bar is so high for skin clearance. Like, we just don't need this therapy there. But there are all these other conditions where we probably have these mixed inflammatory states that, hitting something like this that's a little broader. So if we carry the analogy of the sniper, right, that little shotgun, maybe we hit multiple pathways that shuts off some of these diseases. So I think it's worth exploring. My experience, when I'm honest, is that in every space where this has been tested, it hasn't seemed to be a slam dunk, right? When you add this to a patient who has joint disease that's on a targeted therapy, I have never seen a patient like, that was it. You hit it, like it turned off my joint disease. And I've wanted that to happen, right? I was training when people talked about like, this works really well for palmar-plantar pustulosis. It never worked for those patients, right? I just didn't see that. So people talked about how this was a special niche. So, I think it's worth trying to look at this as an oral therapy for other diseases, but you still have the limitations of a small molecule. And it's not that I just don't like this pathway, right? Like, I like all science, but the problem is that small molecules just don't hit targets very well, right? They don't stay on target very well. So it's going to have limitations there. And I think there are other broader acting molecules where this class becomes a problem is against the JAK inhibitors. Because the JAK inhibitors, I think from the very beginning, their plan was to get in through an easy gateway like psoriasis or AD, but their real goal was to get to all the other conditions where there were no approved therapies. And that broader mechanism of action, I think, works a little bit better. So, will there be something where I can tell you right now that I think that this is where PDE4 is driving this disease? I can't think of anything, but you look at the studies, they keep trying this, and you got to give it to them that way for trying. But I just think this pathway doesn't hit one of them strong enough that I'm not sure. This may actually be an ideal therapy as an adjunct therapy to something else, as opposed to a monotherapy. That's my honest thoughts.
What would it be that adjunct? What would you be adding it to if you were to?
Yeah, I mean, it might be that you have something that works really well. Let's take something like HS, where, we can get some pretty good disease control, but not enough, right? And then you start adding the benefit there. The real sell to this early on was that people lose weight, but it's like, if you feel horrible, then you don't eat, you're going to lose some weight. But that wasn't a draw. But I think it didn't hit a lot of those pathways really well. But I think you might pick up some inhibition with some other pathways to a monotherapy that could be useful. But I haven't seen a really strong scientific basis for this as a monotherapy. But as the purist from the science, like if you find it, like I'll tell that story if it hits there, but I just haven't seen it yet.
Fair. So when it comes to the PDE4s, obviously we know what the orals are capable of when it comes to side effects. Are you seeing it with the topicals at all? I know the warnings there for the diarrhea, nausea, but is that something you're encountering in topical therapy?
Yeah, early on there was this thought that the oral PDE4s, cause GI side effects, and if you apply this topical and some of these people were getting, GI side effects, was it absorbing, right? Were you getting this absorption systemic? That I think was kind of a myth. That didn't really make sense. The problem in clinical trials is that we report side effects, these adverse events, and they're reported because it's a requirement through the FDA, right? If a patient comes in and they're on any of these oral or topicals and they get COVID, we have to report they got COVID. It becomes an adverse event. Well, it shows up in the label and you're like, oh, COVID, it causes COVID. Well, it doesn't cause COVID, right? And in the same studies that we have with topicals, for example, when we see things like headache or diarrhea, right? Like those are common things that people get. And we don't get a chance to adjudicate those. So, I love talking about the safety stuff because there's so much garbage that ends up in some of these education modules or even some of the prescribing information, if I'm being honest, because I'm like, this doesn't make sense, right? These patients, we know these patients, we know their stories. Why are we reporting this as a side effect? So it's a limitation. And, on the FDA website, they talk about how they don't have to have a cause and effect. They don't have to have a direct correlation. There just has to be some reasonable evidence that it's higher in this treatment group versus the other group. And so, I think the topicals really aren't seeing the systemic side effects. I think that's not really played out. What's been interesting with the newer topicals is that both in the aryl hydrocarbon and the PDE-4 space, these patients, we've done a better job at hitting the inflammatory pathway. That one of the value props is that patients can use treatment for a little while and stop and have this prolonged clearance. And that's a value prop to patients because you don't want to put something on once or twice a day, right? Even once a day. If there's periods where you can stop, that simplifies life for a lot of these patients. So I do think these therapies are getting into sort of this conversation around that maybe we can use this less frequently. Maybe these patients can use it a couple of times a week and kind of really keep things under control, and that kind of lowers their overall burden. But I don't think they're not leading to systemic side effects, for example.
Now, when you're initiating these therapies topically, the steroids are home runs initially, right? They're going to work fast. They're going to work really well. How do you set expectations for patients when the topicals that are non-steroidal may not work quite as quickly? Or do you?
Yeah, I mean, there's very few patients that walk in, they're like, oh, I love my topicals. These are awesome, right? Nobody's like, I want to keep putting steroids on all the time. This is so great. That just doesn't happen. There are people who will come in and be like, the topical steroid works well if I use it. And that's kind of what they're saying to you. And we see these patients all the time that, when you come in and they bring in their, combination, they don't even know when they got it and it's expired. And they're just like, oh, here's my bag of stuff, right? And if you ask them, they're like, when I use it, it works. But then they immediately tell you, but I don't want to use it. I don't want to be on a steroid. I think social media has kind of exaggerated this a little bit, but not in a bad way, because I do think steroids have been inappropriately used. And so it's usually not hard to get patients to want to get off their steroids. right? Because I've never once had a patient like, no, I don't know, I really love this steroid and I don't want to switch. So when you tell them like, look, here's a therapy you can use that's not twice a day, that doesn't have the drawbacks, you can't overuse it, it's not going to thin your skin, right? Like that's an easy sell. And I think that conversation you don't get pushback on. But I think if you explain that, these medications may not work as fast, but they kind of work over time, that drawback for them is enough to get the benefits of not using something that inherently they feel like it's bad. So I think you just have to be realistic with patients. If you're going to use a TIC2, for example, oral TIC2, you just got to tell patients like, you got to wait 6 months. You just have to, because until 6 months, you're not going to know where you're going to get to. And I think with the topicals, you're having that same conversation, but they're like, that's fine. If I can just once a day and not be a steroid and I can simplify it, use it anywhere on the body, like that is enough for a lot of patients. And it makes sense that I'd probably be in that camp too.
When we think about kind of future directions, I'm going to nerd out a little bit, but in your last talk with, obesity and psoriasis, we know that obesity fat cells are pro-inflammatory. And I know that apremilast definitely causes GI issues, right?
Yeah.
And people can lose weight from that. But there have been some studies showing that apremilast in and of itself does reduce visceral fat and can increase GLP-1. Do you see any role with combining GLP-1s and apremilast to have some sort of additive effect to help maybe that patient with more mild disease, psoriasis, for example, who is obese, to kind of get them on the right train, if you will?
Yeah, I think the studies around the impact on weight they've been hit or miss. I don't think there's a really strong thread there. I think there's definitely been some metabolic benefits. And I think, trying to kind of salvage where this medication stays, I think you're going for what you can. And I do think that there's some science that backs up the metabolic effects, but I think they're minimal. I think it's still a hard sell in a mild psoriasis patient because you want to get them better. Now, on the counter side, there are patients that I've had who came in on apremilast that had mild or moderate disease who were completely clear. And my general practice is to not take someone off something that's working well. So if you have a patient that comes in that's on apremilast doing well, and they've said they've had weight loss and their skin's clear, then you really don't have an incentive to change them. You could make an argument that maybe suppressing that systemic inflammation a little bit better might be more beneficial. But I think we tend to stay in the path of, if you're clear and doing well, I don't really want to change that. And so I don't know what the future will be for the PDE-4s, but the newer therapies that are coming out, there's an undeniable link. And so I think you would be choosing a therapy that had a modest impact on ones that have really dramatic impacts. And so I don't know that you'd want to add it because you may sort of amplify some of the GI side effects. But, the fun part of science for us is you to just try crazy things and see what happens. Sometimes somebody's like, I have no idea if this drug's going to work, and it does. And so, I think the mad scientist part of science is the fun part. Somebody gets to say, like, we think this is going to work, and we're going to add it in these patients. And, I'm definitely like all comer, like, bring the science. Like, if the data looks good, we'll go out there and support it. And so I'm in favor of trying to find a place for all of the MOAs. I think we want to know where the drugs work. We want to know where to apply them. But I think as we get better and better therapies, like, some of these MOAs are probably going to be underutilized or less utilized because, the science is evolving so fast. I mean, the ability AI is being used to find better targets. Like, they're actually using these algorithms to find ways to develop proteins and drugs. I think there's going to be a lot of competition in this space, but I'm not sure where that might work.
And competition is good, right?
Competition's always good for our patients.
So one of my first experiences with roflumilast foam was a black male, kind of that severe seb derm mixed with psoriasis or SIBO psoriasis. I gave him top of the foam, and within 4 weeks, not only was all the inflammation completely clear, but his pigmentation was remarkably better. He had a lot of hypopigmentation. What are your thoughts on that? I know there's some publications and data on it, and is there a future for this medication in vitiligo patients and repigmenting the skin?
Yeah, so when I go back to the basic science of vitiligo, we know that it probably has a strong Th1. And so when we look at some of the JAK inhibitors, for example, then it's probably driven mostly by, type 1 inflammation or interferons, for example. There's some other cytokines that probably play a role, but certainly you have a mechanism where you're going to hit some of the Th1. The question is, are you going to hit it enough? And vitiligo is challenging. Hyperpigmentation, post-inflammatory, or hypopigmentation may be a little bit easier, actually. Like if there's some impact on kind of establishing homeostasis there for pigmentation. That's one thing. But what's been really interesting is when we hit patients really hard with vitiligo with really strong immunosuppressive targeted medications, they're only getting better in areas mostly where they have sun exposure, which is pretty interesting. So we're seeing on the face and the hands and the arms improvement, but, on the butt, for example, it's covered all the time. We're not seeing much pigmentation. So there's this combination between the sun and repigmentation. I think it's a area where we don't really have any great therapies yet, but I think Th1 is probably the predominant pathway there. And so, I think from at least a high level conceptual standpoint, then, that may have some impact.
Thank you so much. It's been really enlightening, and we appreciate your blunt honesty here. But thank you for doing this.
The enduring content of this episode is sponsored by Arcutis.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.